Hello everyone. In this video, I will be discussing about agricultural poisons from K. Narayana Reddy. First, let us see what is the classification of agricultural poisons. Agricultural poisons can be currently classified into virtually harmless group, comparatively harmless group, mild toxic group, highly toxic group. In that virtually harmless, just remember one example, they are fungicides. They are usually used as fungicides. In comparatively harmless, remember sodium chloride. Mildly toxic, remember DDT and gamaxin of linting. And highly toxic, always remember Paris green, hydrocyanic acid, dinitrophenol, okay, and organic polyphosphates. Just remember these much examples. Once we go into this, let us discuss about the most commonly used poison for zoocide in India, that is organophosphorus compound. They are esters of phosphoric acid. They are of two types. One is alkyl phosphate, another one is aryl phosphate. Okay, there is no need that you have to remember the examples of, okay, all those are the factorial names, okay, it is the chemical and branch names of alkyl and aryl phosphate, no need to remember. Coming into the absorption, remember most of them are absorbed by inhalation, then through the skin, mucous membrane, and via the gastrointestinal tract following ingestion. When sprayed in air, absorption in the plants occurs through leaves and stems. And remember, metabolism always occurs in the liver with the help of cytochrome P450 monoxygenase detoxification system, and excretions of metabolite occurs in the urine. They are mixed usually with a solvent, okay, usually Aromax. That is why OPCs have the characteristic kerosene-like smell in the body cavities. Coming into the mechanism of action, remember, they are powerful inhibitors of acetylcholinesterases. What is the function of acetylcholinesterase? It to degrade acetylcholine. Acetylcholine is an important neurotransmitter in the neuromuscular junction that aids muscle contraction. So acetylcholinesterase degrade acetylcholine. So when the acetylcholine is degraded, what will happen? The muscle has to undergo relaxation. So this process is inhibited by organophosphate compounds. So they are powerful inhibitors of acetylcholinesterase enzyme. The true cholinesterases are found in the red cells, nervous tissue, and the skeletal cells, and very important in the brain. In plasma, we have another form of acetylcholinesterase that is called as the pseudocholinesterase. Okay, yes. So this organophosphorus compound will bind firmly to the esterase enzyme, inactivating it by phosphorylation at the neuromuscular junction and the synapses of the ganglion. Okay, yes. So this phosphorylated acetylcholinesterase will loses an alkyl group. As a result, the enzyme cannot spontaneously hydrolyze and it becomes permanently inactivated. That is why these OPCs are called as cholinesterase inhibitors. Remember, this inactivation becomes irreversible after how many hours? 26 to 36 hours. Fine. So when we say mild poisoning, when we say moderate poisoning, when we say severe poisoning, mild poisoning usually occurs when the cholinesterase activity is 20 to 50% of normal. If it is 10 to 20% of normal, we call it as moderate poisoning, and if it is 10% of normal, we call it as severe poisoning. Coming into the symptoms, they are similar to those resulting from acetylcholine overdose. Okay, and they have three distinct actions. Just remember muscarinic effect, nicotine-like stimulation, and CNS stimulation. In muscarinic effects, we have what? The so-called as the stimulation of the salivary and sweat glands, urinary bladder will be contracted, cardiac sinus node will be blocked, okay, and the nicotine-like stimulation is responsible for the twitchings of the eyelids, tongue, okay, and the facial muscles, and the CNS stimulation is responsible for the headache, giddiness, restlessness, and everything. Coming to the signs and symptoms, okay, it completely depends how far the nicotinic, muscarinic, and CNS is stimulated, okay, yes, and most of the respiratory symptoms will resemble most likely to an acute attack of asthma. Coming into the muscarinic manifestation, which can be removed with the famous acronym that is LUDGE, salivation, lacrimation, urination, defecation, gastrointestinal distress, and MSS. In bronchial tree, there will be bronchoconstriction. In GIT, there will be salivation, fecal incontinence, diarrhea, vomiting. Sweat glands, there is increased sweating, increased salivation, lacrimal glands, increased lacrimation. okay, and urinary incontinence with meiosis, very very important, meiosis. Nicotinic manifestations, it includes muscle weakness because of the accumulation of the acetylcholine. As I told you, acetylcholine is not getting degraded because the acetylcholine esterase enzyme is inhibited by our OPCs. And in sympathetic ganglion, hypertension, tachycardia, pallor, mydriasis. Remember, hypertension, tachycardia both occurs because of the sympathetic ganglion stimulation. It has been a previous year MCQ. And restlessness, headache, tremors, anxiety, drowsiness, confusion, coma, everything because of the CNS manifestation. I told you mild, moderate, and severe poisoning. Mild poisoning means just nausea and minimal muscle weakness. Moderate means sludge will be there. Severe poisoning, sludge with the autonomic dysfunction and breathlessness, fasciculations, seizures, and everything. Remember, we have something called as accumulation of porphyrin in the lacrimal glands because of this OPC compound, that is called chromolacriuria, shedding of red tears. Then coming into the two important sequelae of OPC poisoning, one is called intermediate syndrome and another one is called as delayed peripheral neuropathy. Okay, first, what is intermediate syndrome? After consumption of OPC, in 1 to 2 days, okay, or 1 to 4 days, the muscle weakness and paralysis will be there. Okay, so after 1 to 4 days of consuming the OPCs, there will be muscle weakness and paralysis, especially characterized by motor cranial nerve palsy. Okay, and remember, this intermediate syndrome, there is no treatment as such. Okay, there is no treatment as such. This is again an MCQ. Is there any treatment for intermediate syndrome? There is no treatment for intermediate syndrome. Sometimes after 5 weeks, okay, there is something called as delayed peripheral neuropathy, in which the patient will experience of paresthesias, pain or cramps in the calf, followed by ataxia, weakness, and toe drop. Okay, that is. Here comes the question, which of the following sequelae of the OPC poisoning mimics GBS? What is GBS? Guillain-Barré syndrome. Guillain-Barré syndrome occurs following Campylobacter jejuni infection, which there will be areflexia, ascending flaccid paralysis. This ascending flaccid paralysis mimics delayed peripheral neuropathy following OPC poison. Coming into the fatal period, remember, in untreated case, within 24 hours, death will happen. And the cause of death is because of respiratory arrest, respiratory muscle weakness, and respiratory failure. So coming into diagnosis, yes, what is the diagnostic test? Always we go for remember just one thing, that is cholinesterase determination. I told you, based on the amount of cholinesterase level in the plasma, we will classify the poison as mild, moderate, and severe. Coming into treatment, first we have to remove the patient from the source of exposure and all those. We have to do the gastric lavage when the patient is ingesting OPC poisoning within 3 hours with 1 in 5,000 potassium permanganate solution. And remember, atropine, okay, atropine sulfate is currently given. Why? Because it arrests the muscarinic effects of the postganglionic parasympathetic system. Very very important. What is the drug of choice? What is the first drug actually we give? You immediately inject atropine, okay, because it is actually going to control all the muscarinic effects. But remember, it has no effect on the nicotinic actions. For nicotinic action, we use another drug that is called as oxime, and the current drug that we use in our clinical setup, that is called as pralidoxime, okay, which is an acetylcholinesterase reactivate inhibitors, which will remove the it will prevent the formation of the phosphorylate enzyme and directly detoxify the OPCs, and as a result, it decreases the amount of atropine required and also potentiate the action. See, actually, we actually usually administer atropine along with oxime, because this oximes will potentiate, it increases the action of atropine, and at the same time oximes take care of the nicotinic manifestations. So what do you mean by the end point of atropinization? That means till what time I have to keep continuing my atropine dose? Remember, until the tracheobronchial tree is completely cleared of all the secretion. Earlier we used to give atropine based on the pupillary status. In OPC poison there is meiosis. When the pupil size becomes normal, we will stop giving atropine. But currently the guidelines are saying we should give atropine based on the respiratory secretions and the secretions in the tracheobronchial tree, and not based on the pupillary action. Coming into the prophylaxis, yes. If the patient is in severe pulmonary edema and everything, we can have to use positive pressure ventilation also. Then coming into the prophylaxis, protective clothing, face and hands should be thoroughly washed and all those things. And postmortem appearance, remember, the face will be congested, there will be cyanosis, because all these are the signs of asphyxia. Stomach contents will have the smell of the kerosene, and there will be submucous petechial hemorrhages in the stomach, very very important. Lung shows congestion, excessive edema, okay, yes. And again, brain, all the organs appears congested, okay, yes. Okay, and that's about the OPCs. And then coming into carbamate. In carbamate, just remember, unlike OPCs, where the symptoms starts a bit later, within 15 minutes itself, the carbamates, okay, carbamates are actually, they are actually much more toxic than our organophosphorus compound, okay, and they will spontaneously hydrolyze from the cholinesterase enzymatic site within 24 to 48 hours, but whereas the organophosphonates will not. Organophosphorus compounds are irreversible cholinesterase inhibitors, whereas carbamates, they are not irreversible inhibitors. And at the same time, carbamates are having one more advantage. Why? Because the CNS toxicity, they can't penetrate the central nervous system, blood brain barrier. That is why carbamates are in a bit more safer zone. Okay, but when it comes to the symptoms wise, initially the symptoms of following carbamate injection is very quick and spontaneous. And remember again, atropine is the specific antidote, and for carbamates, never use pralidoxime or any other oxime compounds. Okay, yes, oximes are contraindicated in carbamate poisoning. And in organochlorines, we have the most important compound, that is entrin, and that is also called as plant penicillin. Okay, plant penicillin, this is a very commonly asked short note question, but you read OPC, you will read carbamate, but you will forget to read entrin. Entrin is a polycyclic polychlorinated hydrocarbon which belongs to a group of cyclodiene insecticides. It is actually a dieldrin stereoisomer. It is a type of soluble aromatic hydrocarbon. Okay, and it is very broadly used as an insecticide. Okay, yes. And coming to the symptoms, within 1 to 6 hours, salivation, nausea, vomiting, abdominal pain, diarrhea, restlessness, irritability, and very, very important, unlike OPC poisoning where there is meiosis, here there will be mydriasis. Very, very important. Don't write meiosis here. There is dilated pupil. Rest every clinical feature same like OPC poisoning. Okay. And coming into the fatal dose, 5 to 6 gram, no need to remember, 1 to several hours is the fatal period. And of course, smell of kerosene, signs of asphyxia, everything. And even in putrefied body, entrin or plant penicillin can be detected. Treatment, clothing should be removed, gastric lavage, give activated charcoal. Okay, and remember, calcium gluconate is useful. Calcium gluconate is useful. There is no specific antidote. Unlike, we can't use like atropine and pralidoxime here, unlike OPCs and carbamates. Here, there is no specific antidote. We can just give supportive treatment, dextrose, naloxone, thiamine. Okay, if there is any convulsion, we can give diazepam or lorazepam followed by phenobarbital. Calcium gluconate is also used. Okay, so the same thing happens in rest of the other poison. And let us discuss about one most important topic that you again forget to read, that is aluminium phosphide. Aluminium phosphide is widely available in the name of Selphos. It is a pesticide, insecticide, and rodenticide. Again, it is a short note question you forgot to read. It is in the chemical form is ALPH3. Okay, it liberates the phosphine gas, which is a systemic poison which affects all organs of the body, and it has a garlicky odor. Okay, aluminium phosphide has a garlicky odor. Coming into the absorption and excretion, phosphine is rapidly absorbed from the GI tract. Okay, by simple diffusion, and it is also metabolized in the liver, especially the phosphine gas, and this phosphine gas is excreted in unchanged form through the lungs. And coming to the action, it inhibits the respiratory chain. Okay, it has a cytotoxic action. We have the respiratory electron transport system. No, yeah, it actually inhibits the cytochrome oxidase. And the fatal dose is 1 to 3 tablets. Fatal period is 1 to 4 hours. Very fatal, aluminium phosphide. Okay, and signs and symptoms, it depends upon the mode of exposure. Suppose if it is inhalation, by inhalation it is the phosphate gas, there will be acute respiratory distress, chest pain, nausea, vomiting, diarrhea, headache. Okay, and severe toxicity causes adult respiratory distress syndrome, cardiac arrhythmia, conjunctive heart failure. Remember, cardiac arrhythmias are one of the most fatal manifestation of aluminium phosphide, that is our Selphos. Then if it is ingestion, means it will be a type of nausea, vomiting, headache. Okay, that is non-specific symptom. Just remember the following clinical features: hypotension, shock, okay, unexplained hypotension shock, arrhythmias, jaundice, renal failure, muscle wasting, okay, bleeding, diathesis. And remember, the most common cause of death is cardiogenic. These are the characteristic injuries. Actually, this has been asked in AIMS. Okay, unknown poison with the cardiogenic shock, muscle wasting, hypotension shock, arrhythmia, jaundice. What is the poison? It is aluminium phosphide, that is Selphos. And I told you, garlic-like odor, blood-stained froth, mucous membrane will be congested, lungs, spleen, brain, everything will be congested, and it is toxic to the liver. So centrizonal hemorrhagic necrosis will also be seen. And the most famous test is silver nitrate test. Silver nitrate test is positive. Okay, blackish appearance. Okay, and the silver nitrate paper is test is used for the detection of aluminium phosphide. Again, this will be mentioned in your question. Gastric lavage can be given, activated charcoal can be given. But remember, there is no specific antidote. Here comes one question: which of the following drug is approved for the use of aluminium phosphide poisoning? It is MEGSELF, that is magnesium sulfide, because it reduces the organ toxicity, especially it corrects rapidly. It corrects the most fatal complication. But the most fatal complication I told, cardiac arrhythmias are are very rapidly corrected by our aluminum phosphate. So this has been a question. Okay, again in AIMS they asked aluminum phosphate, what drug can be used? It is magnesium sulfate. Even though there is no specific antidote, MEG-SELF has a very very crucial impact in the treatment and recovery of the patient, and even metabolic acidosis and everything can be corrected by sodium bicarbonate. In last resort, we go for hemodialysis. So with this, we complete agricultural poison.